Hello, everyone, and welcome to today's program, The Future of Health. Today's event is presented by CityAge and Communitech and sponsored by Manulife, WSIB, Ontario, TD, and Sonova. I'll be your anchor today, Zara Alani, and I'm coming at you live from Vancouver, British Columbia. Thank you all so much for joining us. In today's episode, health administrators, researchers, practitioners, funders, partners, and tech founders are here today to discuss how to build the future of Canadian healthcare and the future of Canadian health technology. We have some daunting challenges when it comes to healthcare in Canada, but we also have some of the world's best tech innovators who are building solutions. Today's program, we're figuring out how we can solve Canadian problems with Canadian technology, seize new opportunities in Canadian healthcare, and grow Canada's health tech and medtech startup ecosystems. To start things off and to engage with you all at home, we have an audience poll question. It's going to pop up on your screen, and the question is, what is the best way to improve healthcare and patient outcomes in Canada? There are 4 options for you to choose from. Please pick the answer you think is best suited, and we will reveal the results later in the show. Thank you so much for participating in the poll question. Now we're going to have more throughout the show as we go along. Before we get started, though, a few quick notes about the comment section. So if you look down on your Zoom screen and you want to comment in the chat section, make sure to direct your comments and questions to everyone. There'll be a pop-up choice menu there. This ensures that we see all of your comments. When you choose everyone, it goes to all of us. So for direct messages, though, to the panelists, change the setting to choose panelists. You can head down there right now, choose everyone, and tell us where you're Zooming from. I'd love to hear. Now, first, before we start going into our program, we're going to hear from the program manager for Communitech's Future of Health program, Danielle Braun Carlin. She's here to tell us a bit about the vision behind the program. Welcome, Danielle. I'll hand it over to you.
Okay, thank you. Free universal healthcare is essential to the Canadian identity as is hockey. In 2004, when the CBC asked Canadians to pick the greatest ever Canadian, they didn't select Maurice the Rocket Richard, Gordie Howe, or Wayne Gretzky. They chose Tommy Douglas, who introduced Canada's first publicly funded healthcare system when he became Premier of Saskatchewan in 1944. Canadians pride themselves on our relatively equitable access to physician and healthcare services. Relative to many other nations, we fared well during the COVID-19 pandemic, but there are still many areas to improve and fault lines that this health crisis uncovered. So this brings me to ask, if our healthcare is so foundational to the Canadian identity, why is Canada's healthcare system doing so well on some fronts and so poorly on others? The issue is that our free universal healthcare isn't free or universal. Among many other challenges, issues related to interoperability, access, and systems design have become increasingly important in recent years. At Communitech, nothing gets us more excited than to take on these challenges by facilitating a national discussion and searching for solutions by working with our partners and other hubs to leverage the innovation capital that we have in Canada through barn raising. Instead of having a federal healthcare system in which good ideas can be shared and adopted widely, Canada has a collection of silos that rarely cooperate. To begin to overcome the barriers and access and innovation, we must begin to work together across these systems and break down the silos. Here at Communitech, we take barn raising seriously. It's foundational to the success of our community and organization. It's important to focus on this concept now in the Canadian healthcare journey. By committing to improving our healthcare system, we're committing to the common good and a decision that impacts how we want to define our nation. Barn raising occurs when a community actively decides to come together to work toward a common goal. Everyone in a community, from carpenters, the laborers, farmer, and the cook, they play a different role and a different skill set. By working separately, none of these people would be able to build the barn, but by working together and sharing their time and skills, they're able to build something great that will benefit their entire community. It's the power of 1 + 1 = 3, and it's the model that we're using for the Future of Health program at Communitech. We're building a collective that will positively impact Canada's healthcare system. We're bringing together an assembly of expertise from healthcare workers, strategic innovators, researchers, funders, and health and medtech founders, and inviting them to take a critical look at our healthcare system, accelerate healthcare innovation, remove the barriers, and break down silos. By doing this, we're establishing a community to support our world-class companies, innovators, and leaders in the Canadian healthcare space. In Canada, we know we have the passion, the knowledge, and the talent, and this paralleled with the collaborative nature of the Future of Health program, we will accelerate insights, understanding, and solutions to build the barn and improve healthcare for all. I also want to recognize our partners who are supporting the Future of Health program and the advancement of healthcare innovation. We thank our title sponsor, Manulife, as well as WSIB, Sonova, TD Canada Trust, and Wawanesa Insurance, who are not only supporting this program financially, but they're demonstrating their commitment and dedication to answering the question of why our healthcare system, which is so central to the Canadian identity, is falling short. Thanks also go to CityAge, who partnered with us for this event. All of you are already supporting the Future of Health by joining us today. But if you'd like more information on how you can do your part in building the barn, I encourage you to reach out. I'd love to hear from you and tell you about the exciting work that we're doing. Together, we have the opportunity to take problems and turn them into possibilities and make Tommy Douglas's dream a reality. I hope that you'll join us. Thank you.
Thank you so much, Danielle. Now let's check out the results from that first poll question. The question was, what is the best way to improve healthcare and patient outcomes in Canada? And it looks like there was a tie between two answers involving and engaging patients in the decisions and involving clinical practitioners in innovation processes. Now it's time for another question. You'll see it pop up on your screen. And the question is, what are the most significant challenges facing Canadian healthcare? There are 4 options. Please choose which one you think is best suited, and we will reveal the results later on in the show. Now, while you are choosing that option, let me start to introduce the next leg of the show. We're talking about the recent Globe and Mail series, Fixing Healthcare, which explores everything from wait times, why 15% of Canadians don't have a family doctor, coverage for therapy, to caring for the aging population. The piece explored 10 defining challenges in Canada's health system and 10 potential solutions to them. One of the doctors who wrote the piece is here with us today to share their findings and what we can do to improve Canada's healthcare system. Please welcome Dr. Robert Bell. He is a professor emeritus in the Department of Surgery at the University of Toronto, former Deputy Minister of Health for Ontario, and former Chief Executive Officer of the University Health Network. Thanks for joining us, Dr. Bell. Over to you.
Thanks very much, Sarah, and thanks to CityAge and Communitech for the opportunity to discuss the work that you've already described. Was published in 11 opinion pieces in the Globe and Mail with co-authors Anne Golden, Paul Aloss, and Lionel Robbins. All of us have been interested in Canada's publicly funded health system for years from a variety of approaches. Anne Golden from the social determinants of health, Paul from his interest in cancer research and fundraising, and Lionel Robbins as chair of the Princess Margaret Cancer Foundation in Toronto, interest in how people perceive the health system and his private sector roots brought to bear in this. If I could have the next slide, please. So we set out on this project recognizing that the pandemic has created an insistence in Canada that our health system must improve. And really what we heard from consumers, what we heard from patients, what we heard from a variety of voices was that improvement needs to occur in 2 fundamental aspects of health system delivery. The first is the issue of access, which we know, whether it's the Commonwealth Fund or whether it's cocktail conversations, the issue of how you get access to the healthcare system in Canada is a defining concern for Canadians and really defines the problems in our system in international studies, like the Commonwealth Fund. You know, one of the answers to this issue of access, and also the other issue that defines our post-pandemic concerns, and that is how we manage seniors in our Canadian health systems. One of the answers that's frequently heard and expressed in various opinions is that we need private investment in the healthcare system. We need to invest in a two-tier system. My co-authors and I felt that this is not the case, and we looked for 10 potential solutions that could actually be enacted within our publicly funded system, oftentimes cost-effective solutions, all solutions that could be looked at today with resources that are available. Next slide, please. And for this talk, we've looked at the issue of how does this relate to technology? And certainly one of the biggest issues that Canadians express is access to primary care. That's expressed in two ways. First of all, I don't have a primary care doctor and I can't get a primary care provider. That's something that is told to us by 15% of Canadians who don't have access to primary care. The paradigm that's existed across the country is that we need more family doctors. And while we undoubtedly need more family doctors to care for an increasing population, we also need to widen the width of our perspective in terms of who can provide primary care, who can provide access. And our argument in this piece is that nurse practitioners have been shown in multiple randomized controlled studies to provide care for the generalist concerns that are brought to primary care providers, as well as family doctors. Nurse practitioners can't provide all the services that primary care doctors can, but they certainly provide most of the services provided in office practice. And we think, indeed, that broadening the definition of primary care providers beyond simply family doctors to include nurse practitioners and other practitioners could start to deal with the issue of primary care access in a way that is at least no more expensive than the system we're currently using, possibly cheaper, and certainly as high quality. In terms of access, in terms of technology, we need better ways to measure access to primary care. We need to be able to measure that on a system-wide basis, but we also need to manage for accountability. We need to measure access to each primary care practice in a way that governments can use to determine accountability for primary care services in the system that is really foundational to Canadian healthcare. Primary care is the foundation. We need to measure better, and we need to broaden the definition of who provides primary care. Next slide, please. The other access problem that Canadians are concerned about, and this is one that they hear from others as much as they experience themselves, is access to specialists. And you know, the fact that, as we all know, the fax is still the fundamental tool of communication that leads to specialist appointments is one of the big concerns that exists for especially referral in Canada. Faxes get lost, and faxes cannot provide ministries of health with the information they need to understand where bottlenecks in the system exist and where health human resources need to be enhanced. The only wait time information we have for specialist referral is for patients who end up getting surgery, for patients referred for non-surgical reasons, or for patients referred to surgeons who don't get surgery. We simply have no information. Electronic referral, electronic consultation are products that are available across the country today. We need more of a sense of urgency to bring these to bear, not only to improve the time it takes to see a specialist, since these devices send patients to the person who has the shortest waiting list in that specialty list, but also to allow patients to understand where their referral is in the chain, in the queue of requests to the specialist. We can tell where our Purolator boxes are. We know when Amazon is shipping us things. We have no idea when the fax is going to get us a specialist appointment. That needs to change. Next slide. Time for surgery. Most Canadians don't need surgery on any given day, but Canadians are concerned. They see the experiences of people waiting for total hips and total knees whose progressive quality of life is deteriorating day by day while they wait, especially following the pandemic. You've all seen the data, the number of people who are waiting. Canada can achieve an immediate improvement with surgical throughput by moving probably about 40 to 50% of surgery occurring in hospitals into community surgery centers. This has been demonstrated in other jurisdictions, including the United States and jurisdictions like Ottawa, where the Riverside Hospital has established a broad community surgery program as increasing throughput immediately by 30%, expanding surgery by 30% to deal with the backlog is simply an essential change that needs to occur faster, better, and more cost effectively than the way we're providing surgery today. This is an important change we think should occur in our system today. Next slide. You know, people wait and wait and wait for mental health consultation in our system. We only need to look at the experience in the national health system in the UK and in Australia to see the opportunity for expansion of talk therapy, which has been demonstrated to be as effective as medication, if not more effective, for the most common mental health conditions. Mood disorders, anxiety, and depression fit into this category, and there's great information demonstrating the effectiveness of talk therapy for these conditions in most cases, sometimes combined with pharmaceuticals. In Canada, it's a roll of the dice as to whether or not patients have access to mental health services. Providing therapy, private insurance provides some of this, but we simply need to make this accessible to all Canadians who have mood disorders. In the recent Ontario election, the New Democratic Party, as part of their platform, costed this provision of service for Ontario at about $1.15 billion on a $65 billion budget. We know that mental health concerns, especially anxiety and depression, have been increased by the pandemic. And this is something that we must and can afford to make available to Canadians. Next slide. Pharmacare. We know that pharmacare is something that's essential for the health of about, again, 15% of Canadians don't have access to medications. And the issue of technology in this space is really essential. We describe in this article 4 essential steps to introduce pharmacare for Canadians that include lowering the price of drugs by allowing private providers to get access to the Pan-Canadian Pharmaceutical Alliance prices. But one of the other issues that needs to happen to allow the federal government to participate in a provincial area of constitutional authority is for the federal government to continue to insist it will pay for drugs for rare diseases. A strategy. Canada is the only Western nation that doesn't have a strategy for treatment of rare diseases. And if rare diseases are going to be treated, we need to have a registry system, a technology system that allows us to collect data across the country for outcomes achieved by new drugs. Conditional reimbursement will be part of that. This is an area where technology has to play a role in terms of providing us with information about treatment for rare diseases, which will be an essential linchpin, in my belief, for introduction to pharmacare. Next slide. You know, one of the key people that we learned about during the pandemic providing service in the healthcare system is, of course, what they call in Ontario, personal support workers, sometimes healthcare aid. There are a variety of terms applied. And there are well over 100,000 people providing this service in Ontario alone. People that we don't pay a lot of attention to, but people who are essential for home care, for providing care in long-term care in retirement homes. And the education and especially the job trajectory for people working in this essential function is something that needs to be a firm part of a new strategy for seniors care in our country. We need to elevate this role. We need to think about how we attract people. And we especially need to think of the job and career trajectory that allows personal support workers to function to their full scope of practice in providing care for seniors, hopefully mainly in the community. Next slide. You know, and when we think about seniors care, the thing that, again, we learned fundamentally from the pandemic was that institutional care of seniors is dangerous. We know it's dangerous during a pandemic like COVID, But we know that it's also dangerous during gastrointestinal disease outbreaks, during influenza outbreaks. We need to think about ways that we can decrease the number of Canadians that need to be looked after in nursing homes and long-term care homes. And part of that is thinking about the social support as well as the medical support of Canadians with increasing frailty, with early signs of dementia or even advancing dementia. One of the elements is to look at where these people live, and the concept of naturally occurring retirement communities, or NORCs, a concept that's developed a real importance in the United States around how to provide social services. The current model oftentimes to support seniors with home care is to send 15 different home care agencies into the same building to care for the 30 people living there, excuse me, who require home care. Wouldn't it be smarter to think about asking the residents of that building how they want their home care services provided, and think of 3 or 4 home care workers who are actually assigned not to individuals within that building, but to the people living in the building? They would be providing services to all those individuals. A sense of community developing then, as well as a sense of understanding who the care providers are, a sense of trust that would develop with the same care providers providing treatment to all people in that naturally occurring retirement community, providing some of the most intimate home care or some of the most intimate healthcare services that we afford to seniors. Certainly paying attention to the social circumstance and the residential circumstance that seniors find themselves in has to be part of a new senior strategy stemming from the pandemic and the lessons learned about the danger of bringing seniors together in long-term care homes. Next slide. And, finally, the lessons learned from the pandemic about long-term care, they varied across the country, certainly in central Canada and Ontario and Quebec. Terrible outcomes with a high incidence of mortality in our provinces occurring within these settings. An excellent paper provided by the CMA and Deloitte looks at the increasing demand for both home care and nursing home care by the demographic change in our country that will peak sometime around 2031, 2032. Up to that time, we're looking at about a 5.4% compound annual growth rate in the kinds of services that seniors over the age of 80, for example, will require. Just the demographics indicate that kind of an increase. It doesn't go on forever, but we need to accept the fact in planning our healthcare budgets that the cost of the demand for increased home care and increased nursing home care is going to be increasing at about 5.4% every year for at least the next 10 years. Something we have to wrap our heads around, something we can afford. We spend less on long-term care than any Western nation, something we have to deal with. Next slide, please. So if you want reference to these articles, you can see it here on a website where you can gain access to this. We certainly do not believe that it's necessary to think about private investment, private insurance. We don't need a two-tier system in this country. What we need to do is accept the fact that some costs are absolutely necessary, the costs that I've discussed regarding the care of the increased number of aging people in our country, but lots of changes that we can make to solve the issue of access, thinking about scope of practice of a variety of different providers, and thinking about technology that can be implemented in measuring accountability for access in primary care, certainly thinking about e-referral and e-consult, thinking about the ways that we keep central surgery wait lists, thinking about mental health resources that can be provided online through technology. There are simply a number of things that we can be doing today to make care faster, better, and in many cases, more cost-effective. So thanks for the invitation to attend this, was it barnstorming or barn raising? I can't remember. Anyway, something to do with the barn. We're building a barn, folks, and it's a pleasure to be here and to chat with you about this. Thank you for the opportunity.
Thank you so much, Robert. Now, as we go along with the program, we have the results from our last poll question on what you thought are the most significant challenges facing our healthcare. And it looks like, once again, the audience is pretty torn between two audiences. Now, we are going to discuss that just shortly on our show, but before we get to that, we have another question. Now, the poll question is, what's the first step to addressing our challenges in Canadian healthcare? Now, we're going to move on to our first panel discussion. How do we define our challenges? So Canadian healthcare has some very daunting challenges that it needs to overcome. Our first panel will address what some of those challenges are, how we can get better at identifying them quickly and with precision, and the role that data plays. So I'm happy to introduce our first panel. First, we have Jennifer Shiels, the Vice President and Chief Innovation Officer for Horizon Health Network. Welcome, Jennifer. Next is Dr. Brian Courtney, Chief Medical Officer and co-founder at Courtney Medical, and he's also a cardiologist at Sunnybrook HSC. Our final panelist is Alan Forster, EVP and Chief Innovation and Quality Officer at the Ottawa Hospital. Our panel host is Andre Picard, the award-winning health reporter and columnist for the Globe and Mail. Thank you all for joining us. I look forward to the discussion. Andre, I'll pass it over to you.
Great. Thank you for that great introduction of the panel. I want to get right into it because we have a lot to talk about. I thought I'd start with you, Alan Foster, if I could. We heard in Bob Bell's opening presentation that, there's a lot to fix in Canadian healthcare. We need some innovation. But what's the barrier? What's the biggest single barrier to you for us embracing innovation in Canadian healthcare?
I think the biggest single barrier for us is that we're very provider-centric. We're not a patient or population, person-centered culture within the health system. And fundamentally, that stops us asking the question, are we meeting the needs of our populations? Are we meeting the needs of our patients? And subsequently, that limits our ability to actually change and adapt.
And I'm certain that's not the only barrier. I'm sure you can think of a couple of others aside from being provider-centric.
Well, ultimately, if we want to think deeper levels than that sort of basic cause, that does lead to a number of different challenges. From an organizational point of view, Bob talked a little bit about being provider-centric or siloed between provinces, but we're equally siloed even within a local jurisdiction where we might have different hospitals, we might have different providers, we might have different non-traditional support systems for patients and families, absolutely not connected to each other, all with separate agreements with government or with other payers, all not sharing any information or data to support the transitions across those silos. And for a patient or for a family to navigate that can be almost impossible. It leads to errors, it leads to confusion. There's often bottlenecks at different phases along the way. And that is really detrimental to almost everything we do. If you wanted to go even a bit further, how we even budget our systems, and I talked about those silos, we're at the whim of a process for budgeting that on the one hand is quite good. We are assured of support largely from the government, but on the other hand, we're often left concerned, unknown. It's unknown how much money we will have to invest in improvement activities up until the last minute. So to create a sustainment or an investment approach can be very, very difficult. And again, that's not happening necessarily in a coordinated fashion across the system. So those are very high level, I know, Andre, but I'll leave it at that.
Jennifer Shiels, welcome. Maybe you could weigh in on that. We keep hearing that word silos over and over again. How do silos in Canadian healthcare, how are they a barrier to innovation?
Well, I think, I represent a unique demographic in Canada. We're here in Atlantic Canada, and our population is nowhere near the size of some of these large centers that you see out west or in Ontario. And what I do recognize is that in attempts to coordinate, the reality is we have all common problems across the healthcare sector, and it's unreasonable to expect that we're able to individually solve all of these problems in a way that we're not partnering together. And part of our reality is that, as mentioned, we're running fiscally based on the government's mandate of that fiscal year, or under the direction of a current government. And it's very hard to look at that from a sustainability point of view. I would recognize that in our jurisdiction here in Atlantic Canada, there are partners that we have across Atlantic that are far more mature than ourselves, perhaps with an innovation program, and trying to establish that framework so it is sustainable and has continuity across multiple fiscal years. We're early in our journey of lifting our own organizational innovation framework that will allow us to be a little more agile and sustainable. But some of the unique work that we're doing right now in partnering with the Can Health Network and establishing the Atlantic edge of the Can Health Network is, I feel, leapfrogging us to establish that type of a connected, integrated marketplace, and allowing us to collaborate more effectively in trying to determine who's best at this point in time to solve a common problem, so that you don't have to look at your funnel and try to solve every problem individually, because we just can't resource that.
And maybe talk a little bit more about the Can Health Network. It's the Atlantic province is getting together and being more efficient by working together.
Yeah, well, we're really fortunate. We're just entering our second year in operating the Atlantic Edge. And when I call it an edge, it's a partnership of Atlantic-based healthcare organizations, operators. We have 8 healthcare organizations in Atlantic Canada, collectively working to solve some of our common problems. But we were really excited about the opportunity that came forward, learning from all of the progress that had been started with the Ontario Edge and the Western Edge, and learning early on what some of the projects that came forward from the work that they had been collaborating with industry on, working with Canadian innovators. It's really exciting when you talk about working with Canadian founders and Canadian industry to solve Canadian patient problems. And so all of a sudden there's an intimacy that doesn't really normally exist in this marketplace. And the excitement and energy that comes from that, it really is a unique environment to work within. It motivates our clinicians in a very different way. Because you're not just trying to explain, okay, we're Canadian healthcare, we are a little bit different. We're a publicly funded healthcare system, we're a little bit different. Some of what might motivate financial gains and revenue generation in other jurisdictions, we're more motivated by patient outcomes. We're more motivated about population health. We're more motivated about creating efficiencies, because we have a very challenged, a specialized recruitment issue happening in Canadian healthcare right now. So if we're not really looking at innovative ways to create efficiencies in how we operate, we're not looking at long-term sustainability of our healthcare system. So, looking at digital health solutions and these technologies is really their investments in sustainability of our healthcare system.
Great. And Dr. Brian Courtney, thanks for your patience for joining our panel today. Now, you're both a clinician, you're a cardiologist, and you're an entrepreneur. I imagine you see different barriers to innovation wearing those individual hats. Maybe you could talk a little bit about those.
Yeah, absolutely. I mean, I trained in California for medical school, came back to Canada wanting to contribute to an innovation medtech ecosystem in Canada. Did that about 18 years ago. And I've identified a few barriers. One of them is how do hospitals and universities manage intellectual property? Another one is when you're in the States, there are big companies like Medtronic and Boston Scientific and Johnson & Johnson, where they build talent that knows how to build new medical technologies and bring them into clinical practice. We don't have many anchor tenants, if any, of that nature in Canada. We do in the biotech pharma side, maybe not so much on the medical technology device side, although that's changing and that's evolved quite a bit over the past, I would say, 5 years in particular. Our regulatory environment was incredibly challenging compared to the US FDA environment. And I approached Health Canada and the Minister of Finance about 5 or 6 years ago and mentioned the challenges with regulatory issues in Canada. And they actually invested $120 million in a regulatory review of drugs and devices, doubled the size of reviewers for medical devices in Canada just before COVID hit. And all of those interim orders for personal protective equipment, new testing, new therapies would not have been resourced adequately enough without an effort to emphasize, hey, we need to have an agile regulatory system that keeps pace with other jurisdictions. I think the two biggest things that are outstanding right now are really procurement and adoption is one category, and then capital financing for innovation. Canada invests in real estate, mineral resources, high tech, doesn't invest much in medtech. It'll walk away from, Canada doesn't have big investors for medtech innovation right now, which is a bit of a challenge. But as a physician, building new medical technologies and being able to use them on physicians is exciting. I think when patients hear that they're having new devices being used on them, they're saying this is really happening in Canada, and it gets them excited. I'm currently in New York City right now, and we used one of our devices in 2 hospitals yesterday. We're using it in a 3rd today, and we're getting a lot of uptake. And that's a pretty common story to sort of skip the Canadian market for the most part and just go to the US, because medtech is 98% export business. And there isn't a lot of competition to be the first to adopt in Canada. There's a lot of competition to not be the last to adopt, but to be the first, there's no money budgeted for it. There's very little reward for it. And the margins that hospitals operate on really preclude them from making high-risk bets on new innovations that may or may not work. So we need to find ways to reserve some funds to be able to do early innovation adoption and see, is this a good technology? Does it warrant dissemination to the rest of the system or not? Without having to have companies like mine or others, fly to other countries with support teams to see if their system works the way it needs to in a clinical environment. And that'll give us, some economic development opportunities. It'll give us some fundamental research and development opportunities. And it'll actually give us capacities to support supply chain issues, because we'll have local medical device, medical technology, supply chain sources in Canada when we run into issues like we did over the past 2 years. So it's a pretty big dynamic situation. There's a lot to adapt, but very different in terms of the pace at which things happen in the US versus Canada for adoption that could be addressed in part by some structural changes in Canada.
Now, there's a lot in there. You have a lot. I want to ask you 25 questions, but I want to seize on one of them. You talked about medtech being an export market. So does it matter if you have a foothold in Canada? Does it matter that you sell to Canadian institutions, or is that just a bother?
It's a bother, but it matters. So it's a bother because it's twice as much, if not 3 times as much work to comply with Health Canada and the FDA than it is just to apply to be compliant with FDA requirements to get a product onto the market. But it matters because if you're going to make something, being able to get feedback from early users, trusted sources, we have outstanding research and development capacity and clinicians in Canada that are highly underutilized with respect to the ability to get early feedback, see if a product market clinical need fit in fact exists, and to be able to iterate quickly. The iteration process, when your government funding programs, they announce a program for funding innovation, takes a year for them to hire somebody to run it, and then a year to get the program developed, and then a year to review the applications, and another year to actually execute. By the time government funding programs happen, often, the opportunity has been left in sort of the wind. So I think some agility is needed. Sorry, a few emergency services outside my hotel room here distracting me. But I hope that answers your question a little bit.
Yeah, it definitely sounds like New York there with the sirens going. So that's great. So Alan, I want to come back to you because we were just talking about this need to research, to figure out if stuff works. Do we do a good job of that in Canada, having the data and figuring out if these new products actually work?
No, I don't think we do a very good job. And there's multiple layers to that, as Brian was mentioning. I think fundamentally, we don't, in our health system today, we're not paying for value. We're not paying for for the outcomes. We're largely driven by global budgets, and to a certain extent, it doesn't matter what the outcomes are. And you know, to create the incentive and the space for the benefits to start accruing back to an organization, really there needs to be that either capital investment up front or some kind of reward at the back end, or both to happen. So I think fundamentally the incentive structure is not there. I talked a little bit about culture before, about the culture within organizations not necessarily being as patient-centered. The other part about the culture in our organizations is that really around we tend to be very closed within our industry, and we're not looking necessarily to outside capabilities. And so working with technology firms that may have been in other industries and may have tackled many of the challenges we're faced with, becomes almost not accepted because we know better kind of approach. And so really creating an open innovation platform is really a necessary step for moving this forward and can accelerate the culture and the risk taking. And then lastly, about the data, and part of this is about, and I think this is a fundamental issue actually for both the value assessments and working with people from outside, is that we make it very difficult for people to get access to information. And part of that is the basic nature of the information we're dealing with. Obviously, we're dealing with personal health information, and we need to look at new ways of accessing information so that it doesn't put patients' privacy at risk. But similarly, we need to also help make it easy for people to the technical side of things. How do we get people to understand how to use the data to make inferences and to make conclusions and to make those investment decisions that both Brian and Jennifer spoke to. So those are three areas which I think would be worth expanding a little bit on moving forward.
And all of you have made this allusion to the Canadian culture. It seems to be about being overly cautious, not risk-taking. Can we change our way of being? Is that doable?
I think the problem with our current approach is that we don't see the consequences of it. And so we're holding on to this dream of the Tommy Douglas, I think it was mentioned earlier about care for all and equity. And what we're not seeing is that there are negative impacts of doing that. And I think we may end up getting left behind a little bit. And it's a bit like the boiling the frog situation, where things are getting a little bit worse. And then at some point it's going to become very unsustainable to keep things going, and we'll be left quite far behind. So hopefully we can push some change forward before that boiling point is reached. But I'm a bit sometimes I'm a bit skeptical about that.
Now, Jennifer, I want to come back to something Brian said about, it's a bother to be in Canada, but it's still essential. Now, you really put you want to have Canadian vendors. You make that a priority. Talk about why is that important from the system perspective as opposed to the vendor perspective?
Well, I think we all recognize that for industry to be successful, for this specific industry to be successful and to be globally successful, companies have to grow within a very large market. When you look at Canadian population, we're probably around 37 million people across Canada. And when you look at the US market, I mean, you could have our entire national population in one large region. So, if we aren't able to figure out how to operate together as an integrated marketplace, we're not creating a welcome environment for industry to partner with us and innovate with us. So we have to really be intentional with our approach to welcome Canadian innovations to come into our healthcare setting to prove their technologies. And I think each healthcare organization, I'm speaking from a buyer's point of view, I suppose, we have to understand what is our role going to be, and what can we support adequately and intentionally. I'm not a research and development organization. We have lots of tremendous clinical trials happening. When it comes to some of these innovations, we're not an R&D shop, but if I just look up a little bit and look out to my ecosystem, I see outstanding representation in my backyard with different incubators and accelerators that we can partner with in an intentional way to bring innovation into the organization. So our role and what we've identified as the role for us as a partner in an integrated marketplace is not to own the IP necessarily, but it is to absolutely partner with those more mature innovations, open up our environment to see if they solve the problems. And if so, we feel there's a role that we can play in helping to support the scaling of that partner, both within our jurisdiction and across our national integrated marketplace. So I think working together is probably the only viable way for us to really partner in a meaningful way. Our population just can't compete otherwise.
Now, you just said, we're not an R&D shop, but it springs to mind, shouldn't you be? Like, shouldn't this stuff be happening right in the hospital, right in the health system? I know there's a real reluctance in Canadian healthcare. Oh, if we have a vendor in there actually doing stuff, we're all going to go to hell or something because there's a private company in there. But shouldn't we be doing more of this stuff in the day-to-day?
I think the role that we play is opening up our environment to be that living lab. I think we let industry be successful, let them bring their innovations to the table to prove and demonstrate, and then support them for growth and scaling. We're in the business of taking care of patients. And I think there's tremendous, outstanding, creative expertise in the marketplace that they can't even get into our front door with. And our role is to open up that front door and allow them to prove those solutions in our environment.
Great. Brian, if you could come back to the issue of procurement. I hear from a lot of healthcare providers and administrators who are frustrated by that process. You alluded a bit to it, but you see all this new technology, you read the journals, and then, as you said, when are you ever going to get it? Is it going to be 5 years, 10 years? Talk about that frustration.
Yeah, that sort of fits into the bigger concept of this term value-based healthcare, which everyone refers to, but then very few people can implement in practice. So, if you have a technology that you can sell that saves costs on this admission and provides equivalent performance, people will buy it because of the cost constraints in the healthcare system. If you have a technology that improves outcomes, but potentially costs a bit more during the current admission, even though it saves more money for the system globally over the next 5 years, i.e. patient lives longer, patient lives better, Ontario or whichever other province which pays for all healthcare in hospitals ends up saving money globally, it still will not get adopted easily. And that's just because of the siloed nature that was referred to previously. People are focused on the near term. And I think the provider centricity is part of it. Sometimes using these technologies takes a bit more skill, a bit more time. You can't adjust the scheduled benefits for physicians. So if physicians aren't getting paid to spend a bit more time to do something, they're not going to adopt it. And there's no reward for taking that risk of innovation or of going a step further in terms of trying to adopt something at an earlier stage.
On the contrary, there's lots of reward for doing nothing, right? For
accepting the status quo is probably the easiest. And I think that, Alan referred to provider-centric versus patient-centric. I'm not sure how much input patients have into which services are reimbursed by the province. I'm not sure they are often educated about, what technologies might actually improve their outcomes until it becomes really large scale. So stuff at early stages, they don't learn about, or even at moderate stages of adoption, they don't learn about. When something is, when I started practice, we had these bare metal stents that we put into people for coronary disease, and they would block off at about 20% within 6 months. And over the course of time, we used drug-coated stents, which had a 1% restenosis rate associated with them. And eventually patients started asking me, hey, am I getting a drug-coated stent or a bare metal stent? And we probably stuck with bare metal stents for about 5 to 7 years longer than we probably should have had we followed a more agile, rapid adoption curve. And we direct-to-consumer advertising is not allowed in Canada. It's only allowed in the United States and New Zealand. So there are limited opportunities for industry to actually let patients know about what might be helpful to them to make their own decisions or talk to their providers about. So I think we have to find ways to involve patient stakeholders more meaningfully in in the use of adoption and in having in use of new technologies, in making decisions about their care. When I have spoken to patients, I should say, that are involved in early use of technology, they have been incredibly excited about it. So we need to find ways to have good conversations, open, fully disclosed conversations with them about the pros and cons of things that might have some risk because things are new, but do that sooner. I think the population's ready for it. I think it's more in our healthcare system that we need to make those pathways to have earlier adoption happen more rapidly and break down some of the things like contract purchasing, where you're committed to a single vendor for 3 to 5 years before you can actually come in with a new technology. That's a big issue that happens in our single payer healthcare system.
Yeah, I think patients are definitely more savvy and less patient than they used to be. So hopefully that'll bring about some change. Alan, I want to come back to something you said in passing. We hear whenever the topic of innovation comes up, we hear, well, healthcare is different. We're not like banking. We're not like transport. We're different. Is it really that different, or is that just an excuse?
I think that's an excuse. That's my opinion. Really, many of the problems we're faced with have been dealt with previously in other industries. Even Jennifer's comments today and Brian's comments kind of almost underline that. We're having to talk about working together. If you worked for a bank, if you worked for the Royal Bank, there would be no way that the branch down the street would work differently than the branch that you're in today, let alone the branches around the world. Similarly, they have standards with respect to sharing information, so that if you do change to the TD Bank or Bank of Commerce, you will actually get the same information standardized in the same way. So fundamentally, I think there's a failure to accept standards. There's a failure to view the industry as a service provider. We still tend to run as a sort of cottage hospital, cottage industry approach, where we all work solving, as I think Jennifer said, solving the problem in our own way each time, and not scaling properly. So I do think there's a bunch of issues sort of cooked in there, Andre, that we need to kind of break up. And I also think that, just kind of getting back to that open innovation concept that was brought forward, the solution will come from industry. If we work and create pathways for industry to come and work in our institutions in collaboration with us, and we can be the development shop for a lot of different end results of discovery and research from around the world and from within Canada. And I think that's the way forward. I don't see us changing without some outside pressure to help us do that.
Great. Jennifer, I want to come back. A lot of vendors in the audience. I wondered if you just give them some practical advice when they approach a health system, someone like you. What are they doing right and what are they doing wrong? What could they do better to get their products uptaken?
Well, I think, in terms of, my own marketplace that I work within, and what I'm hoping will come forward from our industry partners, I am looking for those more mature, commercially viable solutions. I have a more of an appetite with my physicians and clinicians to work in a clinical setting or clinical environment with those solutions that are just about ready to support scaling and commercialization. For us, what we've found to be really helpful is leveraging a methodology where we actually issue a call for innovation, and it's part of the methodology within the CanHealth framework. And the call for innovation is sort of putting out the problem statement and actually eliciting response from industry on how they might be able to come to the table to address that challenge. And what we've done with several of these initiatives and projects already, let's say that's a common problem between ourselves here in New Brunswick and our partners in Newfoundland at Eastern Health. I might not have the cycles right now to run that project, but Eastern Health is willing to do so. Then I might provide some physician advisors to sit as an advisory board on that project. So we're tapped into it. And then when we start to run that project, we have immediate insights into how it's progressing. And when it's finalized, we can determine early on if it's something that we would want to also adopt or jump into. So partnering in this way across an Atlantic jurisdiction, we found it to be unique. The call for innovation, it's not procurement exercise. It's just putting out an opportunity to partner with us with an innovation framework wrapped around it. It is also indicating that we have a commitment to solve the problem. So we have money that we like to procure with, but you have to prove it in our environment before we would ever start a procurement process. The commitment for us as well in this scenario is, once we can prove that there's an innovation out there that can solve our problem, we'll probably run an RFP to procure it. But we're going to introduce it to an integrated marketplace with all of our national partners to say, who else would like to be part of this RFP with us? So it's stepping into this ready marketplace environment that hopefully we're supporting these folks who are willing to take a risk and work with us and test their solution in our environment. And on the outside of that, if it's successful, we'll support them with scaling.
Okay. And Brian, on the theme of practical advice, Conavi has been successful both in Canada and the US, which isn't the case for everyone. I wondered if you could offer some advice to people in the audience. What was your secret sauce? What are the hard-earned lessons you could share with some of them?
I mean, it's a lot of perseverance. It's associating yourself with people that are supportive. Just to give you a few examples, Sunnybrook, when you walk in the front door, there's a sign that says inventing the future of healthcare. And that's a culture change within our institution. Even at earlier stages than when you're ready for mass adoption and RFPs, there's a lot of steps between when an idea is born to when it's ready for large market adoption. And Conavi's not quite there yet. It's getting there, but it's not quite there yet. I think we've had some great collaboration from government. I think it'd be good to see private funding sources step in more. And I think success will breed success. A company in Mississauga called Bayless just sold to Boston Scientific for almost $2 billion. That certainly demonstrates the potential value of Canadian-born technologies on international marketplaces. And it involves the discussions like this that really help people move forward. I think mentorship is a key part of it as well. I think people who have gone through going from an idea to seeing it adopted at early stages to seeing large scale adoption is one of the most critical pieces that you can have as far as advisors or as far as employees in an organization to really affect change at international scale.
Great. We just have a couple of minutes left. So I want to ask each of you, send us home with a message about, what's the single most important thing we could do today in Canadian healthcare to improve on the innovation side, to make it better? Maybe I'll put Alan on the spot first. What's the one thing you would do tomorrow to have the most impact?
Greater transparency on the benefit of our services in terms of outcomes to people and to populations, as well as consistency across provinces and jurisdictions.
Great. I think I see a secret formula on the board behind you. So
exactly.
We're going to take a photo of that too and share it. Jennifer, what's your one thing you'd like to see change tomorrow that would really have an impact?
Well, I wish it could change tomorrow, but I think what we're seeing is culture change happening, and that doesn't happen overnight. So I think from a horizon point of view, we're just starting on that journey to really embrace the idea of creating a culture change. I love what Brian had said about those bold statements when you walk into the front door of an organization. And, it's at all levels of the organization where it's supported and endorsed and embraced that you understand that you are able to engage with innovation and ideas to bring them forward to improve how we're working together, how we're improving the health and well-being of our citizens. And I think culture change is where our energy needs to focus right now. And that's what we're trying to do.
Great. And Brian, the final word. I know you gave us about 10 things that should change in the opening question, but pick one that would have the biggest impact tomorrow.
I think that if we were to find ways to be much more agile in the procurement and reimbursement of new technologies, I think that would be the biggest one. That would generate the carrot that pulls everything along. But right now, there are a lot of protected interests that protect how physicians are reimbursed because they don't want to change things, even though they might not provide much in the way of outcomes. So if we can take the schedule of benefits and smash that against the wall and rewrite it in a way that is linked towards outcomes and patient needs, I think that would drive a lot for innovation and for patient care.
Great. I think that schedule of benefits may smash the wall because it's about 600 pages long, but it definitely needs some reworking for sure. So thank you very much to our panelists, Alan Forster, Jennifer Shiels, Brian Courtney. I'm going to turn it back over to Zara, and thank you all for being there.
Wonderful. Thank you, everyone. Thank you to our panel for that very informative and engaging discussion. It does leave us a lot to think about. And I want to thank all of you at home for participating in the poll questions. Now, the last question was, what's the first step to addressing our challenges in Canadian healthcare? And when we looked at the results, it was pretty spread apart, really saying that we need to address a variety of issues. Now, before we get into our next discussion, we do have one final question. What is the most exciting area of opportunity in the Canadian health sector right now? Please choose the answer you think fits best, and we will reveal the result later. But following in the theme of that question, we are concluding the program with a discussion about current unique opportunities to not only solve our problems, but to open up new avenues for innovation. Please help me to welcome the experts who are going to tell us how to best seize those opportunities using Canadian technology. First, we have Dr. Jodi Abbot, the president and CEO of the University Hospital Foundation, one of North America's top healthcare foundations. Amir Hayeri is with us, founder and chief executive officer of Bioconscious Technologies Incorporated. And our final panelist is Balaji Gopalan, CEO and co-founder of MedTech. And hosting the panel is David Reevely, reporter at The Logic. Everyone, welcome, and I'll leave it to you to take over.
Thanks so much, Zara, and thank you all for being part of this. I'm a reporter for The Logic. We cover technology and innovation and the future of the Canadian economy generally. And one of my areas of responsibility is health technology and how it is evolving, particularly at this really important time when people have been paying more attention, I think, to health and science than really any time before in my lifetime. But I come to this from the background as a provincial affairs reporter for a while at the Ottawa Citizen, so covering health systems, which are much of what any provincial government does, but from the perspective of patients and service levels and building new things and how the public interacts with these systems. So it's interesting for me to kind of go behind the curtain in a sense and look at the technologies that are underlying a lot of these changes and what needs to happen. So the question I want to start with for the panelists, and I'll begin with Balaji, is what effects have you seen from the pandemic that are positive? What are some of the endless debates that we had, or some of the obstacles that we couldn't seem to overcome that now, even if the pandemic isn't in the rearview mirror, at least those obstacles seem to be? What are some things that we're doing now that we never thought we could?
Yes, thank you, David. And I think it's a really interesting way of characterizing the question. And I'm extremely honored to be here today to talk about this very important topic. The most interesting thing I think I've seen in the ecosystem of digital healthcare technology that's evolved or changed because of the pandemic is we might have expected that this situation we're all in drove the creation of a whole bunch of new sort of approaches to healthcare in this context, or new technologies, which did happen. But the more interesting thing I think was happening was an accelerated adoption of things that were already in development. So those of us who work in the field of digitization of healthcare or digital application of healthcare technology have always seen these opportunities to provide smarter, more intuitive, more central patient experiences that place a highlight on measuring the things we actually want to measure in today's healthcare context, which is something that was talked about in the last panel. But I think the industry has suffered a little bit because these things were were built with all of the right intentions of patient outcomes in mind, but the path to adoption was difficult. And even if not difficult, just very long. All of a sudden, the healthcare industry faced the same sorts of challenges that every other industry faced in terms of restrictions of access, in terms of even restrictions of just having people in the same place at the same time, thinking about an emergency room, for example. And so we looked as a society to say, well, healthcare is continuing, we still have to provide care. What are the ways that we can do this in this new context? And we were fortunate that people were already working on things like remote patient monitoring and telemedicine and home care technologies, and extending care beyond traditional settings into extended settings. To me, that was the biggest advantage. And the outcome of this has been that even as you say, the pandemic isn't quite over yet, but we're certainly not in the same situation we were in a few months ago. There's been some shift back to what we may think of as a sort of traditional healthcare context, but not entirely. People have sort of realized that some of these things are actually better experiences, even outside of a pandemic situation, and I think that's really exciting. So
like what are some things that we've done kind of by accident that we want to keep, that you see?
Yeah, I think virtual care is the most obvious one. Even some sort of personal stories I can share. I had family members that I think in a previous environment would have had to arrange transportation. And I live in Toronto and not even in the middle of Toronto. And to facilitate travel down to a downtown health facility for an appointment, those appointments were then done virtually. And that's now continuing because it was actually seen, well, we didn't really lose. In this particular healthcare context, we didn't lose very much. I think that's really interesting. I also think there's been an increased focus on continuity of care outside of the facility, which takes on a number of different forms, whether it's digital monitoring technologies, whether it's things that now empower the patient to monitor themselves, or even things like extending care through home care services into the home. There's been more attention about ways we can enable this stuff and then track it through digital technologies.
Jodi Abbot, what's your perspective on this? What's changed in the institutions where you work for the better from the pandemic?
Yeah, I think it falls really nicely on what Balaji said. And an example from our hospital, the University of Alberta Hospital, they started a virtual hospital in 2018. And I would say it started quite slowly, but the acceleration really happened. And what they were able to do is create about 60 virtual beds. So not only did they use digital technology to support patients, but they actually broke down the barriers between hospital and community. So if you were having surgery or you needed to be in a medicine bed, you may be in the hospital for a short period of time, you would be discharged home, you would be digitally monitored from home, and the providers would come to you. And a really, really great example on reducing emergency visits. So for those with surgery, we saw a 51% decrease in emergency visits. That's unbelievable. And we saw a 94% increase in patient or 94% patient satisfaction and provider satisfaction. So I think what that did is we were able to use technology to do that, but we also broke down, I think, some of the typical silos that we heard of in the earlier panel. And we're now looking at this across the entire system in Alberta. And certainly from a foundation perspective, we fund innovations like this. So it's a really good example of how donor dollars, so really community dollars, are helping to accelerate new ways of doing things in hospital. And if we can free up emergency visits, surgical beds, it means we can actually reduce wait lists, et cetera. So I think it's a really good example of how something got accelerated because of COVID and all of the impact to the health system.
Of those 60 beds, virtual beds, how many of those have stuck How many are still there today?
They're there and they're actually growing. So it's really interesting because they're moving this now across the entire province. So it's now being seen as a new way of doing business, and providers were happy with it as well as the patients. So I really think this is something that can continue on post the tremendous impact from COVID.
So, Amir, at BioConscious, what have you seen from the pandemic that's a positive, systemic changes and obstacles that we've overcome that we get to live with the benefits of?
Yeah, so going off of what the other panelists said, I think it just, opened people's horizons, if you will. So we work, for instance, with patients with type 1 and type 2 diabetes. And before the pandemic, obviously the technology, telemonitoring, this is obviously not new, existed before the pandemic. But when we wanted to actually get this into a healthcare system, or when we wanted to approach, small practices, small to medium size, and ask them, hey, you know what, we have this system we would like to deploy, they would always ask us, like, why would I want to remotely monitor my patients, or why would I want them to stay at home? I deal with patients with low to moderate activity. So the fact that they're coming into the office, that's even better. I want them to come into the office, right? So it was really, really hard to explain, the value proposition, the fact that they have to change the medicine, and the way they're practicing medicine, if you will. For us, that was a little bit of a blessing in disguise, because now, especially with patients with hypertension and diabetes, you don't want them, to get COVID, because they're at higher risk and poor outcomes, if you will. So all of a sudden, it went from something very nice to have to, oh, actually, this is the only way of doing it, at least, in the thick of the pandemic, if you will. Obviously, now we are not done with the pandemic. Everybody reacts like the pandemic is done. It's still here. It's not top of the news, but we're not through it yet. At least, for the time being, we now have a hybrid situation where for the high-risk patients, we don't have to explain the value proposition and the reasons as to why they have to do it. For the ones that are slightly moderate risk, or they want to leave the house, obviously, yes, absolutely, there's the opportunity. You can go to your doctor, you can have that personal interaction. But, rest assured your data is being monitored, so you don't have to go to your doctor for them to review your data. You don't have to be doing exactly the same thing that you were doing. So for us, it kind of made it easier to let people know what the value proposition is, how they can monitor it. And I think it's literally allowed us to open up new doors. So for instance, I really like the concept of virtual beds. We do the same thing. We have devices that patients can use at home. They generate medical grade data. But so far we've had not the right opportunity or the right tools to get all this information aggregated in a cohesive manner, if you will, and then analyze it and put it in front of a healthcare professional in time. The pandemic really, really pushed us to put these, systems in place. And I think that was for the better.
I want to talk about technology adoption at different kinds of health institutions and practices. And so, Amir, I'm going to stick with you on this. Who do you find is the most eager to adopt the technology that you're offering and the services that you're offering? And who's the toughest sell?
Well, the toughest sell are insurance and health networks. We operate in the US, so do take this with a grain of salt. But in the US, we found that, most of the value, what we do is we have an AI system that's able to learn glucose fluctuations and then predict the onset of complications. And, for different events, it does, it has different horizons. So it can predict a patient's HbA1c 6 months ahead of time, or it can predict an onset of nocturnal hypoglycemia 8 hours before it happens, et cetera, et cetera. So what we found out is that the bulk of the value is created at the insurance and payer level. So they, first thought, they should be open to it. And they should be like, oh my God, this is awesome. Let's implement this tomorrow. But when we went to them, we found them to be very reluctant, slow movers, show us the value, show us a bunch of studies, okay, now 7 different people need to sign off on this before we can even get to a pilot phase, not, licensing or anything like that, but just piloting it. So the flip side of it for us was actually going after small to medium-sized clinics in the US specifically. And these are clinics that are outside of the network, looking to join a network, relatively new practices that are, up and coming, if you will. So we went after them. And for us, it's going to the clinic, just, studying the clinic a little bit, if you will, trying to understand what do they need, and then can our software actually help them? And in a lot of cases, dealing with smaller to medium-sized clinics, yes, the bulk of the value is not created there. It's at the payer level, but even when you're approaching a smaller practice that wants to, use these technologies, and with the new practices, their appetite is much bigger, if you will, for trying new things and deploying new types of technologies. One or two people are involved in the decision-making process. So you're potentially looking at a much shorter buying cycle as well. So for us, we're a startup, so we have to be very strategic with all of our resources, time being, the most scarce one, if you will. So for us, going to organizations where there is a little bit of value, we can show traction, and, it's a shorter buying cycle, made the most sense. Now, this might not be the same thing for the other panelists. So I hope that was helpful.
Yeah, Balaji, I saw you nodding vigorously when Amir was talking about newer practices and newer doctors being more receptive to this stuff. I know in reporting about electronic medical records, one of the biggest problems is the kind of the last meter getting adoption in solo practitioners' offices, or where there are just a couple of doctors, particularly in smaller communities where there might just be one family doctor with a zillion patients, and he or she's 10 years past retirement but can't go because there'd be no doctors. And so it's one thing to get new technology writ large into a hospital or a large urban practice, but how do you make the pitch and make reasonable demands of people who are running very small operations?
Yeah, I thought there was an element of the story that Amir just shared that I thought was really, really interesting, and a light bulb kind of went off for me, which is why I was nodding so vigorously. I think there's two ways to think about the implementing of digital health technologies, and what I do in my business is I get to see lots of people building stuff. So we get a perspective on what may be working and what may be a little bit more challenged. One area is transforming the workflow of people who work in healthcare, whether that's in a small clinic or in a large institution. And another perspective, and I, grain of salt, I am being a little bit overly simplistic here, but another perspective is to change the life of the patient. And in so doing, then providing a data input or a decision input into the clinical environment that they can use without them having to change too much of what they're already doing. And I think that's what's really magical about the kind of thing that Amir is working on, and companies very much like Bioconscious Technologies, is they're looking at saying, well, how do we improve the monitoring and management of the patient outside of the clinical environment so that the clinician can make better decisions? As soon as you try to change everything that's happening inside the healthcare environment itself, and in the world of some of the biggest costs of healthcare being chronic conditions, so much of healthcare is actually outside of the walls of institutions. It extends beyond that. Then if you try to do it that way, then you run into the challenges of multiple levels of decision making on one side at large institutions, as you talked about, David. And on the other side, clinicians, and I know some of them personally, who are just trying to get through the day, and they don't have sort of a space to sort of say, well, how do I maybe pause and do things differently, because they have reports to file, they have patients to see, they have a business to run. However, when you create a new paradigm outside of the clinical environment, you have a great opportunity to invent the integration of this data and this workflow into the clinical environment, particularly for newer practices, which quite often are small, right? I think I'm not an expert in sort of the demographics here, but my colleagues here would know better than I would, but I think you're going to probably see a bit of a bell curve in terms of small clinics of people early in their career who may be more open to doing things a little bit differently on one end, and people who are very late in their career who are just winding down and winding down with a small clinic. In that case, it may be a little bit challenging. But I think if we create a new normal, an overused term, I apologize, but amidst the patient population in dealing with healthcare, which speaks to data transparency, patient empowerment, value-based care, all the things we've talked about, then the system will adopt. And I think even these are some of the things that I sort of read between some of the initiatives that Jodi's doing as well are picking up on some of this.
Let's talk about those. Jodi Abbot, in Edmonton, what are some of actually, first, what are some of the obstacles in a large institution? Because I sort of hand waved that away. But of course, it's not easy in a big place with a lot of stakeholders. What are the obstacles to adopting innovative new technologies in an environment like yours? And what are some of the cool things that you've been able to do in spite of those difficulties?
Yeah, so we're a foundation, and I describe us as being squished between a large academic institution and a large health system. So we're tied to AHS, but tied directly to the university hospital. And our mission really is to be a catalyst for health system transformation. And as we developed our strategic plan, as an example, there were a lot of puzzled people around, well, how can you do that? You're not delivering the care and you're not doing the academic research. So kind of who do you think you are? But we actually believe we sit in a really cool position because we're Switzerland and we raise money. So we work directly with donors who want to see innovation happen. And so being in a large system where the health system and the university have all kinds of encumbrances on them, we can actually be that nimble person in the middle organization to be able to move things forward. So one of the ways that we've been able to move big things forward, and sometimes small things that become big things, is we created a model called strategic partnerships. And we've taken the view that donor dollars are critical and they're part of the public environment. We then put donor dollars, industry dollars, so it can be large industry or it can be an SME, and government dollars together. So we've actually created a P3 model that really is about moving innovation forward. And over a period of about 5 years, we've invested about $26 million around 17 partnerships, and we're funding jointly about 60 projects. And some of these projects really are going to move the needle, or they have moved the needle. So an example is we're working with Roche on the area of MS and using biomarkers to look at the progression of MS rather than having to use a very expensive MRI test every so often. So we're actually using new technologies and bringing what I would call unsuspecting partners to the table, who you may say, well, do you really want industry at the table? And our view is that industry is maturing in terms of their approach to healthcare, because I believe, at least industry partners we have, see that in order to be successful as an industry, they also have to focus on purpose. And there's a lot of research out there that says companies that are purpose-based will actually move the needle on their profits, on what they're trying to achieve. So we've been really deliberate at working at these partners, at these partnerships. And I'm at Bio right now for the very purpose to meet with all the potential partners we can meet with to be able to solve some of the big challenges our hospital and our university have. So it's really a different type of model.
I'm going to flip that question around now and put it to each of you for what I'm going to insist to be a fairly brief answer. And starting with Jodi, how do you make sure that some patients don't get left behind by these things? I'm sitting in my house in downtown Ottawa. There's a little 5G symbol in the upper right of my cell phone screen. I'm wearing an Apple Watch. I love all this stuff. I'm talking to you all on a Zoom call. But I mean, there's the resources, and then there's just the tech savvy. How do you make sure that all these innovations reach people whose first language might not be English or French, who are not familiar with all the kind of technological methods that we're talking about and not really comfortable with them?
So one of the things that we've been very deliberate in our partnership is setting principles at the very beginning. And an example of that is a partnership we have with Boehringer Ingelheim, and it's around lung disease, and it is focused on the Indigenous community. And so it's really looking at how do we ensure inclusion of communities who may have certain challenges in front of them. So we actually try to bake those things in. The other things we're doing is we are moving outside of the hospital environment into the communities, because we realize when you're in an acute care hospital, yes, that is the focus of our hospital. We're a tertiary care center. We do trauma, like that's what we do. But we also know people go home and people want to be served at home. And so what we're really trying to do, and I would say on this front, we're really at the beginning of this journey, is we're trying to understand who are the underserved? How do we reach them? What's the foundation's role in trying to help with that bridge? Because there are the realities of people not having access to technology, et cetera. So we get engaged in things that some might say are outside of our world. So it might be we're working with, for example, the Edmonton Metropolitan Region Board on how do we actually get better internet access for people in the community. And you might say, what's a hospital foundation doing? Well, the reality is that's where care is going to go, and we hope it goes. So let's make sure that people in those communities can be well equipped. And the Alberta government is actually moving forward with an Alberta data strategy where they're going to protect the data of our citizens, but we have access to 4 million people. Imagine being able to use that data in your practice as a clinician to better serve the patient or client that you're seeing.
Amir, bioconscious, I want to get a perspective on this from you. You've got technology that depends on people using it, really, or else it doesn't do any good. How do you make sure that the digital divide that we already have doesn't get deepened in the field of health?
Tough question to answer. That's what I was going to say. So the kind of like the view that we have from the market is a little bit nuanced. So the way we see the market is, we see it as a spectrum. You have your youngsters, high performers, athletes on one end, and then you have your chronically ill, hypertension, cancer, diabetes, et cetera, at the very other end of the spectrum. And then in the middle, let's call these the healthy middle that we're all a part of. We're no longer in our 20s or 30s, right? And somehow we start off on one end and all healthy, and then we end up with a chronic illness, in the other sort of end of the spectrum. And the issue is, my issue with healthcare is that it's not really healthcare, it's more of a sick care. We have a lot of toys for the healthy at the other end, Apple Watch, Fitbit, et cetera, and we have a lot of end of life crisis care management for the other end, and we have absolutely nothing in the middle. So our goal is trying to go a little bit further from the chronic condition and then open our technology to what we call the healthy middle. And the goal here, we believe, and it's a hypothesis that requires validation, is that a lot of times we have diseases developing, but there is a honeymoon phase where, we're either not looking for it or we're letting the disease run. It's like, hey, you know what, my back hurts, but I'm just going to walk it off, right? And we're all guilty of that because, we don't have insurance, because we don't have coverage, because we don't have time, a lot of factors. But anyways, the moral of the story is what we want to do is we want to be able to detect these early on outside of our current, sick care experience. So for instance, we did something outside of our area of expertise around the time of COVID. We were just monitoring people's movement habits and behaviors. And this is the information that you generate and it goes online, whether you want it or not. And we noticed that people's movement patterns are a very good indicator of them getting sick or developing an illness. Unbeknownst to you as the individual, as soon as you feel a little bit under the weather, the very first thing that you're going to limit is your amount of movement. So your regular habits and behavior all of a sudden change. You have a much smaller movement pattern or movement radius, if you will. And so that was a great indicator for telling us that the patient's going to have a complication in the next few days. And in the next few days, we saw that patients are reporting symptoms. So what I would encourage everybody who's here is to, build resources around that part, because today almost everybody has a cell phone, whether they want it or not. It's almost like a limb. And when people leave it behind, I love watching them, or just like frantically looking for their phone. And these gizmos come with tons of sensors. They monitor our habits, behavior. If we have other types of sensors, such as an Apple Watch or Fitbit, you get a lot of extra information on heart rate, oxygen saturation, be it that some of them are not medical grade data and there's some things that you can't do with it, but there are tons of things that you can do with it. I think the appetite after the COVID pandemic is much higher for new tools and new solutions outside of your regular healthcare system. And I think, targeting the healthy middle with the devices that they already have access to would be the best place to start, to make sure we catch these diseases in the asymptomatic or early stage, which they're often earlier. It's easier to reverse rather than catching it when it's already type 2 diabetes. It's not reversible, right? At that point, we've already lost the battle. So that's kind of like my 2 cents on that.
I think that has taken us right up to time, but I'm glad that we got to talk about the distinction between maintaining wellness and sick care, because I think that's really important. Thank you all for being on this panel. This was really a treat. I wish I could pick your brains for much longer. But with that, I will turn it back to Zara. Thanks again.
Thank you so much. Once again, I want to thank our panel. Go ahead. Okay. Well, I want to thank our panel, Dr. Jodi Abbot, Amir Hayeri, Balaji Gopalan, and David Reevely. Now we have the results from our final poll question. Again, fairly evenly spread out amongst the 4 options. And that wraps our poll questions and our CityAge episode, The Future of Health. I want to share a big thank you to our guests, attendees, and of course to our sponsors, Manulife, WSIB Ontario, Sonova, TD, Wawanesa Insurance, and Communitech, the champions of tech for good. We have big healthcare challenges to solve in this country, but with all the people on this call working together, we know we can build a better future. We've been bringing you CityAge virtually from the start of the pandemic, and we're continuing to do that, but we're also back to in-person events. So if you would like to have a CityAge around an idea or topic, please get in touch with us. Our mission is to bring leaders together who are building the future. Until next time, thank you for joining us. I'm Zara Alani. Stay well, and we'll see you on the next one.